My research helpers are a little nervous because I kind of threw this at them at the last minute, so you give them a little support on this. And what I'm going to do is, like many people have done, is I'm going to fly through some of the early material so that we have time to get to the results, because this is a qualitative study where people say things that are really interesting. At least I think they are. So this is a study. I just want to acknowledge my colleagues back at Michigan State who are not here presenting, but have worked hard on this project, and Riebschleger Foundation, which is actually associated with the Dow Chemical Company in Midland. And then you can read that in the book. And I won't go through all these details because you've been at this conference for 3 days, so I don't need to throw these numbers at you, but essentially there are millions and millions, it reminds me of Carl Sagan, millions and millions of children who have apparently the mental illness, and one particularly includes substance abuse, and Tony was going in that. It gets to be so many more. One of the things we're looking at with this model in terms of throwing in theory would be looking at risk and resiliency in child development. So that's kind of where we're coming from. Some basic background literature is that, there's a fair amount of literature that shows that children, as adult children, report that they do not know much of that about mental illness. Some of the children this goes back to some needs assessment that I did long, long ago, that basically said they didn't know much. Yet at the same time, they were living lives that really centered sometimes around the level of symptoms their parents were feeling on good days or bad days, which is how the children thought. It probably is more complex than that. And they don't talk about it much, if at all. And this was what motivated some of the work that I've been doing, and this goes back a few years, but I'll never forget this. Sometimes just somebody says something and it crystallizes for you, and this was my crystallizing comment. And I heard this in different versions many times. If someone had just sat me down and talked to me about this, my life would have been a lot different. Well, I don't know if their life would have been different, but I know that they thought, and that had meaning for them. And I thought, well, we'll just sit down and talk about it. Why don't we do something with this? So, and these are some of the questions that when I talk to children, as children, they ask things like, why do they treat people different? What goes on in the hospital? And they have a lot of questions. So as we began to do this work, and I've been at it for a lot of years, and particularly I've worked in psychoeducation, which is now becoming mental health literacy, as I think there's a better chance for money in it. What the hell's the difference, right? But we know that psychoeducation is an evidence-based adult program. Years and years and decades and multiple studies that show that it works. It works for the families. It works for people who are in services, generally speaking. So we know that in the U.S. that there's all this new stuff, Mental Health America. There are these new, let's go out and teach people how to deal with people who are experiencing a mental health crisis. So that it would be key people who may be on the scene. And so I think, well, okay, so why can't we do psychoeducation with children and then begin my journey a decade or so ago? So one of the things we know in the literature is that we don't know much about developing kind of informational, we're getting better. We go to this conference and I almost need to take that off because I learned so much in this conference about that. But I do know this, I could not find much literature that talked about what consumer parents wanted. My consumer parents, this is a sample drawn from community mental health, public mental health agencies, so in that sense. But we don't know what they want. How do they talk to their children? What do they say to them? Do they want other people to talk to their children? And I thought, well, it doesn't make much sense to design an intervention if I go for somebody's children, and maybe as a parent I understand that even better, but how do I know what they want in there or don't want in there? And we didn't even know if they'd like the idea. So we designed some focus groups that we went in, and we also, I had a parent advisory committee, I don't think I put that up there, but I did have that as well, and they helped us build up questions for the focus groups. This is not a large study, this is a small study, but it is very deep in terms of having a lot of information. And we did a series of focus groups. We were looking at questions like, and we didn't call it psychoeducation, we called it classes with activities. Because that made, I mean, that really is what it is. Sort of like, and we explained what we were thinking about and asked them what they thought and how it would work and how that might work with their families and how it should be scheduled and, you know, all kinds of very specific and in general, you know, what are your ideas? What do you want, content do you want in there? What should not be said? Just kind of threw it wide open about what their ideas were, trying to figure out, and then how, and we use this information very, very much to design the intervention, and to, when we had it going, we continued. And we also then, what I don't have up here is we used a lot of the youth feedback. And so we're now up to group 13 or something, and it keeps getting developed. And other things we did many things. We checked back from the focus groups at the end to make sure and went over the field notes. We looked for places where people disagreed, and we did iterator coding. Those are some researcher kind of stuff, looking for making our data, showing something that could be trusted a little bit. So here's our sample, and we'll go over, but it's basically people who were below the U.S. federal poverty level, mood disorders, thought disorders, half with a history of substance abuse. That data, by the way, that was verified data from the caseworkers who referred people, and we also used. We also had some indication that most of them had some serious mental health symptoms, and most of them were single parents, but not all of them. Okay. So that's kind of what we did. We got this information, and here are some things. Oh, we're like time of great. Okay. Is first of all, we all of our of the parents that we talked to, when we told them what we were thinking about doing, thought that it was a good idea to do classes plus activities. And I could put that up there, but I mean, fancy, so it's psychoeducation. So they think it's a good idea, and these are just a few of the quotes. So you guys, they're going to boost psychodrama for you. Tori, you know what psychodrama is? Tori's a law student. I've been exposing what have you been? Infiltrating her life with social work stuff. Psychodrama is acting things out, how people do things, like in the story. It's like telling a story by being a little theatrical. So, Olivia, show her what psychodrama is. I want you to do this page. Thought she was going to get it, didn't you? Slow, loud, and with some drama.
I think it's good for children, psychoeducation.
Beautiful.
Because I could talk to them until they're blue in the face, but they just look at me like I don't know what I'm talking about.
I can talk to them till they're blue in the face. I can hear her now saying that. And it's like, what, you know, I can say the same. Has anybody been up here and said this? I used to like working in practice because it was like, I could say the same things their parents would say. And they would listen. Their parents go, I said that. I'm like, no, sorry. Get it. Okay. And the second thing we learned, because we were really interested, and there's not a lot of, is what they told their children about mental illness and what they thought their children might know about mental illness. And there's much more that goes with this. But most of them said that they believed that their children had very little or very limited ideas about mental illness. But I didn't put that up here, but primarily derived from media, more of the stigmatized abuse. And they were right. When we did some other work with children, that's exactly what the children that we worked with did have.
A lot of parents said that they did not discuss anything about their mental illness with their child, or they've given their child so much information that they have I've given my child so much to swallow already.
So they had some, in that particular case, it was a woman who had lost custody of her child when she had a serious co-occurring disorder, mental illness, substance abuse. And during that time, she got her child back. They were working on rebuilding, and she thought, so it was her trying to decide when's the right time, which is something we've heard in this conference.
The child won't listen to me, doesn't want to hear it, and it's hard to talk about.
So they said even if they tried to talk to their kids, that didn't mean that their teenage kids wanted to hear it, or that they wanted to hear it in that moment, perhaps. So that some of the times they tried, it would, and that wasn't always a comfortable topic for them to talk about. And a few people, I don't have a quote that says I don't know how to talk about this, but it was kind of the, if I were to paraphrase what I was hearing, that was part of it for some people.
I don't know enough about my mental illness. I don't sugarcoat nothing.
I don't sugarcoat nothing, she was cool. I'm not sure, I don't either, so I thought that was neat. But there were two people in the group who had actually sat their children down and had to be taught, like the years that built up to talk. And one of them sat in front of a computer and they looked up all the stuff over time, several times, and they talked to their children about what they had and what that meant. And the other one said that's just something they talk about like anything else, that wasn't to her that uncomfortable. But the rest of the people were kind of like, not so sure about when to do that and how to do that. Okay. One of the things they did say about the psychoeducation is one of the reasons they thought it might be useful is they thought it would be useful for their children to learn that there's other people, other youth, and this was these were all parents who had a child, school-age child, generally 17 years or younger, but they really varied. They were very young ones. Some of them had disease too, but they all also had school-age child. And so they thought, one of the things is they thought maybe their children did not know that there were all these other kids out there that had the same thing happening in their homes. And so, Tori, you start this one.
Let the kids know that they're not the only ones that has a parent that has a mental illness.
So they thought that part might make some sense. And then they were worried about kids being a little isolated, which actually was, that they didn't always, so.
Kids can connect too, and there might be some really good friendships coming out of it because the kids won't feel so outcast at school. They might be able to connect with the other kids.
So they saw that as, and they understood their children's need for connections and certainly supported that and thought from that standpoint, that made some sense to them. At least with, this was something that they said really heavy. This was heavy in terms of repeated over and over and over again. And we call this a good age because they had that comes from their words. I tend to do en vivo coding using their, so if you see, I'll use things like no sugar coating as a heading and things like that. But, so I tend to like to use their words rather than cleaning it up with and professionalizing it. But a good age, so one of them said you have to have a good age, and then we started to probe about what age do we begin to talk about this.
When we start these groups, break them up by the younger kids, elementary, and then kind of like the teenage, junior, high up through the teens. They have different problems, different friends, relationships.
There are things that can tell a 16-year-old that they wouldn't tell an 11-year-old.
Okay. The other thing they said is their kids are not coming to a regular class. They're not going to go to classes. That's all there is to it. It's too much like school. They're not going to do it. You better make it fun and you better make it lively.
You've got to do some fun things, not just always work on business. You know what I mean? Like play bingo.
Get them involved in it. Get them involved in it. Possibly get them to, act out skits, do things in ways that they're learning, but they don't feel like they're learning.
So I'll do this one. Have things that are creative, fun, interactive, interaction with everyone. That's kind of putting together. That's no. Have prizes. Have prizes. I'm gonna just take a few of these. Refreshments, money. Money, you can always bribe them, they said. They didn't actually say that. And food. Go ahead, we'll do food.
The food helps. One thing that people want when they come to groups is food.
And boy, are they right. And if you ever do one of these groups, triple your budget on food. These are for teenagers. And you think you cannot get enough food for these guys. They eat a ton. Even the girls. All right. Yeah, I was wrong about that. Curriculum content. Here's some things they wanted to talk about. Mental illness as an illness and mental illness and recovery. So we'll just do a few of these because obviously we'll do number 1 and number
They need to realize, okay, you're a human being and you know that sometimes stuff happens.
Stuff happens. They want kids to know stuff happens. Yeah.
I think there should also be taught the group or class or whatever that these diseases that their families are experiencing are real.
They're real. They're not necessarily scary. You can still have a good life even though you have a mental illness. And they spent a lot of time talking about harmful and helpful use of medication. I'm paraphrasing a little bit on that, but we kind of came to that eventually. So it was about, yes, you have to take medication, and that actually was irritability. Can you get it? What did you say?
You worry that they will inherit or acquire addictions or depression and things like that.
They worried about their kids. They watched them. They watched them for symptoms, and they did that.
Yeah, this is a fact that statistically, it's a possibility. This could be the way it is, statistically a possibility.
And person 2 says,
There's hope that there's possibilities.
yeah, you could get this, but there's also possible that you don't get it. They wanted the kids to know that they had an elevated chance or a greater chance, but it didn't mean you had to have it. And they had a lot to say about stigma, even though I didn't put much down for quotes. Stigma was the enemy, definitely. So, good.
No, there's not something wrong with me. There's just not a bad person. Just I'm different.
The stereotypes, mentally ill people are not stupid.
So they said things like, show them all these famous people that have achieved all these things. Abraham Lincoln and, all these famous people with mental, and we do. We do that. Okay? They wanted, and this was I've not seen before, but they said that they wanted the children to know that sometimes they needed some help, but sometimes they just needed them to go outside and play and be kids. And they wanted to kind of not be tiptoeing around them all the time and having a better sense of how to interact across different days.
Identify when the parent might need help in case the parent is not able to identify it themselves.
So also when not to help parents, just to be a kid and have fun. They actually felt guilty. I didn't put this up, but a lot of people expressed what was regret, that their kids had to help them sometimes. They didn't particularly like that, but they recognized that as something that was part of their family. That's just the way it was. Stress management and coping. Huge, huge emphasis on this. And guess what we have in our program? Huge, huge emphasis on this. So they said, teach about stress management or skills.
Skills for us to teach the kids on their level of stress management.
Definitely teach them coping skills.
And avoid using drugs because they're worried about their brains. So teach about brains, they said. And in practice, since we're all running out of time here, I'll handle this part. You guys are good. Did they do good? Okay. So many things that come out of this that we can do. So I now deliver programs in the middle school, in a Michigan middle school, where we have some of these activities. And we work with children and during the school day, which solved our big problem pretty effectively, I have to say. And so we do things like have a coping mobile with children-generated coping strategies hanging from, on the end of these strings. We show how all these things help you stay in balance. With fighting the stress monster, making plans. With baking together the facts of mental illness and recovery. And then my favorite, I don't think up here, but my very favorite, I can't do it anymore because it's during the school day during the day, was they would make anti-stigma posters and we'd go out and march around the building. That was my personal favorite. it didn't work well during the day, so that we kind of had to go. Yes, we have prizes. Yes, we have food. We try to not have it all junk, though. The teachers do not appreciate when we shrivel them up and send them back. And policy, we have a long ways to go. And I understand that what we're doing is with this piece, and the only part that you heard today was about the children's piece. We have a lot more work to do with the broader family issues. And we have also made we need to take a good hard look at this and quit separating mental illness and substance abuse, because they're not separate in families. And research, we have a long ways to go too. There aren't any youth voices in here. There aren't youth voices per se. They are really in there because we use their voices all through. We have data and everything evaluated by them and more. But what I am trying to do is build an evidence-based program. Well, a lot of work, I got to tell you, it really is, many years. So we want to move toward having people or comparison groups. We're getting close. We're getting close. And that's what we did. I told you that. Yeah. Come on, right ish. Suggestions, complaints. We take them all.
It's nice that you bring things over the border, because I recognize a lot of people for my research.
Yeah?
So, yeah.
Okay.
We're the same, actually.
Parents are parents all over the world, right? I mean, that is one thing I've learned from this conference. People are people all over the world. We may not speak the same language, but we speak the same language. I speak a better language, better connecting here than people who speak English.
Do you have any literature that you distribute?
I didn't bring any today, but we do have some of the early, what did we put in? This particular presentation is actually in you got your packet, and they had that special journal. It was written up in that special journal, but not in as much, I mean, we had like, not many words, so you actually got more than is in there, yeah.
So you mentioned going into schools, and one thing that went to my head was Massachusetts, right?
Yeah,
With
I'm from Michigan.
Michigan. With the Common Core curriculum, are you aware of the Common Core curriculum that federal has mandated for all schools when it comes to education? It's really shortened teachers' ability to bring in programs like
I know.
this. Are you finding that that's going to be
Yeah.
a struggle for you?
Yes. So what she's talking about is that there's all this emphasis on, see if I get it wrong, testing. They're really, I mean, it's reading, writing, and arithmetic, it's STEM, science, technology, and we're, in Michigan, there's also something called Michigan Model for School Health, which is a school health model of long standing, which has nothing, by the way, on depression or religious or substance abuse, yes, though some of that, and but it's mostly, obesity fighting and nutrition and reproductive health and things like that. What happens is the schools are under so much pressure to do everything and prove that the kids are learning things that it has impacted greatly their ability to do anything innovative or creative or additional, what you normally would have thought of as social kind of things. But recently, at the same time, we have the Federal Department of Ed now have discovered in their wisdom, nobody's here for that. Nobody's here for that. They have discovered that if a child has some emotional issues or family stressors, they don't do as well on their test scores. Yay! I was excited. The only problem is they're doing their own thing and they're not coordinating, but at least they're going in and starting to go into schools. And actually, they wouldn't talk to me at all because my model's not evidence-based. But I did get to meet with them. They do know this exists. And in Michigan, they have a grant for 5 years, and there's a new RFP out that I'm quite sure they'll. It's called Project Aware. The other one was some kind of.
Are any of these resources available online?
Huh?
Are any of the resources available online? Like what you're doing? Is there?
Yeah, not very well. Is anything available online?
If you want to meet with me afterward, I have all of the resources on my laptop that we use for the program.
Oh, that's right. Yeah.
So I
Well, we really
Show
can't.
you.
I can't give that out. No,
show.
not yet. We can show it. Yeah, you can show it to them. I just can't. I can't handle it.
Take that back.
I've got to gotta get through the spring at first, and then I can, but I'm happy to talk about it all the way. I just can't hand out the manual, but I tell you everything we're doing. We really hit co-occurring pretty hard, and we do zillions of activities. It is fast. Because I've had to change everything to fit in a school day, it's 35 minutes. And you've got to make every minute work, so.
And then, if it's okay, I just want to add, I have my degrees in special education.
Okay.
Just with the schools as well, I've been running into teachers coming to me, or board members at schools type coming to me and saying, because of the stigma of mental illness, even within our special education classrooms and even within kind of non-typical schools, they don't even want to broach the subject of mental illness.
Really?
The stigma is making the school say, let's just not touch on that.
Wow.
You know, intellectual disabilities and all those things, but let's not add this on top. So they have an inappropriate fear,
Wow.
which is preventing
Wow.
discussion of mental illness.
Yeah. Well, one of the things we teach the kids is that, and I need to end, but is that if you go to, is that you can't tell. We also had to do instrument development, and we test pre-post and follow-up. Things like, can you tell if somebody has mental illness by looking at it? Well, you know, they start out thinking you can. They're in wheelchairs, they're slobbering, they can't make this. I'm not making this up. This is how they describe it, because we always ask what are people like. They can't make decisions. They can't have a good life. They're all these terrible things. And these are the children who have a parent with a mental illness and substance abuse, and they're, you know, and they're not connecting that has anything to do with their families, because while they do say occasionally, we don't really encourage a lot of family disclosure, but of course we get a little bit, and we do have the lieutenant governor in our state has a child with autism, and that has done. And then they passed a law that they would do all these things for autism. So now all the schools are doing these autism, which actually, in the advocates are very divided about what to do about that. Because I was one, go for it, we'll build on it from there. That was my stance, but not everybody agreed. But they also mandated what kinds of interventions had to be. The legislator mandated specific interventions to be used for everybody. So go figure. But at any rate, what it's done is, if you go into school, I'm working, and it's Autism Month, they're like, autism's cool, all these kids, drawing, but then now they're quoting that as not a mental illness. It's developing, that's kind of one of those sticky kind of areas. Nonetheless, I do feel that there's and some of the things we also do is involve the principals, the parents. I didn't even get into them. Didn't have time to do the model today, but we try to make sure that everybody knows what we're doing. If it's real broad, even we don't always tell them that the children have a family member, but we tell them that we're teaching the kids about this. That's kind of how we handle the broad public. And so anyways, we're directly using this data, and that is what the consumers had to say in 20 minutes. Thank you so much, you all.